What I'm going to do is go through kind of differential diagnoses and some of the more common and uncommon kidney lesions that we have today. So first, let's talk about differential diagnosis of renal cell carcinoma with clear cytoplasm. And so the first entity that I'm going to talk about is clear cell papillary renal cell tumor versus clear cell renal cell carcinoma and papillary renal cell carcinoma. And I'll show one of these also during the slide seminar. So first of all, let's just talk about the name. So this was formerly called clear cell papillary renal cell carcinoma for many years. We've now changed the term. The latest WHO, and based on numerous studies, including from our own institution, is that these never metastasize. There's never been a single report of a metastasis from this clear cell papillary renal tumor. Consequently, we don't call it carcinoma anymore. We call it clear cell papillary renal cell tumor. And you're going to see that's kind of a recurring theme in renal pathology, that there are some newer entities which so to date have never had reported metastases, and some of them even look cytologically fairly high-grade malignancy, but because they've not been reported to metastasize, we're calling them tumors, not carcinomas. So clear cell papillary renal cell tumor, the predominant pattern is often tubular. So whenever you see a renal tumor that's mostly tubules, you should be with clear cytoplasm, bland cytology, you should be thinking clear cell papillary renal tumor. Clear cell renal cell carcinoma is more nested with that fine vascular pattern, not so much tubular. At one point, people talked about calling these tubulo-papillary renal cell tumors because, again, the tubular component is such a prominent component. And sometimes it can vary how much tubules versus papillary component. Here we see at higher power, again, basically grade 1 cytology, no cytologic atypia, striking clear cytoplasm, just like clear cell RCC. In that sense, they're similar. And in here we see some tubules, some also having little papillary formation as well. A striking finding in clear cell papillary renal tumor, not present in every tubule, but often and typically present somewhere in the case, is what we call reverse polarity, where you basically have the nuclei in the top of the gland with the cytoplasm down below, like day 16, 17 endometrium. We also call it subnuclear vacuoles. Now, this is something that's quite distinctive for clear cell papillary renal tumor, but as I'll show you, is not specific for it. For example, in clear cell renal cell carcinoma, focally, you can sometimes have this reverse polarity. This is a classic example of clear cell papillary renal tumor with all these tubules. The other thing that's typical of these tubules in clear cell papillary renal cell tumor is that these tubules are often blunt-ended. So they kind of come down to a kind of more of a squared-off edge at the base of these lesions. Again, very distinctive, pretty much only seen in this entity. Here, a little higher power, bland cytology, squared-off edges, tubular and papillary component. Sometimes these tumors can be more papillary, somewhat less tubular, as seen, on for example, the bottom left. And a higher power, papillary with, again, the reverse polarity. Immunohistochemistry, so initially it was said you can't make this diagnosis unless you verify it immunohistochemically. I would say currently, if you have a classic H&E morphology of clear cell papillary renal tumor, you don't have to do the immunostains. I think it's diagnostic. There are some cases where I think it's not so straightforward, and to distinguish from clear cell renal cell carcinoma, where I think you have to do the stains. And now, probably more importantly than before when we used to call this clear cell papillary renal cell carcinoma, you could argue, okay, not such a big difference. Look, grade 1 clear cell RCC versus clear cell papillary renal cell cancer. Now it's more important for the pathologist to make the correct diagnosis, because when you call it a clear cell papillary renal tumor, you're basically saying it's benign. So the immuno is, and it's easy to think of the immuno, because think of clear cell papillary. One is clear cell, like clear cell renal cell cancers. They're often CA9 positive, so that's one stain. And then the papillary component, you think of papillary renal cell carcinoma, is typically CK7 positive. So the unique thing about this tumor, which both has clear cell and papillary areas, is it's both diffuse CK7 positive and diffuse CA9 positive. The CA9 is membranous staining, but typically not at the apical. I'll show you a photograph, resulting in what's called a cup shape. If you think of the cups, on your the chalices or cups on your desk right now, you could think of it staining along the edges, but not the surface. So again, these are benign. Typically they're treated by partial or radical nephrectomy. Usually if a biopsy, you can't be 100% to make a definitive diagnosis on biopsy because, as I'll show you, clear cell renal cell carcinomas can have areas that look focally like clear cell papillary renal tumor. So most of the time they are taken out, even if you say it's suggestive of a clear cell papillary renal tumor on biopsy. Again, totally benign, no evidence of metastases. And this is the staining with CA9. So what you can see with the CA9 staining is basically you have staining kind of on the bottom and on the sides, but not on the surface, not on the luminal sides. That gives it kind of a cup-shaped kind of staining. Not entirely specific. Sometimes you can see it in other tumors, but it's more commonly seen in this entity. As I mentioned, however, you can have a clear cell renal cell cancer with areas mimicking clear cell papillary renal cell tumor. So here's a case, and so what you, in a sense, have to do in these cases is say, what does most of this tumor look like? So in this case, 95% of this tumor look like what's on the left side, clear cell RCC. So clear cell RCC are typically solidness of clear cells with this fine, thin vascular pattern. But focally, in this case, you had this tubular component with reverse polarity that, out of context, looks like a clear cell papillary renal tumor. But again, this was just a very minor component in what otherwise was a typical clear cell RCC. So again, you have to look at the majority of the tumor, but that's why, again, you can't definitively diagnose these on biopsy, because if you had gotten a biopsy of this component, you potentially would have made a misdiagnosis if you definitively called it a clear cell papillary renal tumor. Here again is the classic clear cell RCC component, small solid nest, fine vascular network. And here's an area that, out of context, looks just like clear cell papillary renal tumor, but in the context of the whole tumor, was just an area of a clear cell RCC mimicking clear cell papillary renal tumor. Another thing that I think pathologists get confused with is staining. So clear cell renal cell carcinomas diffusely stain with CA9. So in terms of immunos that you should get, if you're seeing any renal pathology, some of the basic stains that you should get are CA9, CK7. I'll talk about cathepsin K a little later. And CD117 is a c-KIT, is one of the other markers. A lot of the other, and CK20 everyone has for various reasons, but can become useful as well. But one thing that many pathologists are not as familiar with is that low-grade clear cell renal cell cancers can have quite a lot of CK7 staining. They never diffuse CK7. Diffuse CK7 rules out a clear cell RCC. If you have diffuse CK7, you should be thinking clear cell papillary renal tumor. But patchy CK7 in a low-grade clear cell renal cell cancer is totally acceptable. So papillary renal cell cancer is also tricky because a papillary renal cell cancer can have some focal clear cell features. It still it can be papillary. So you have to, again, look at kind of the overall tumor. So if you look at this tumor, this is a papillary renal cell carcinoma. And you can see small little papillary projections kind of throughout this lesion. It doesn't look like clear cell at all. There's nice foamy macrophages, which is also typical of papillary renal cell cancer. But focally, there's areas with some cleared out cytoplasm. And that's totally acceptable for papillary renal cell cancer. So again, when you're dealing with kidney pathology, you want to look at kind of the overall what the bulk of the tumor looks like and accept focal areas that may, for example, has clear cell areas in a papillary tumor or clear cell papillary areas in a clear cell RCC are still acceptable, depending what the overall tumor looks like. But here again, high power, this could be clear cell RCC, but in the context of the overall tumor, it was just an area of a papillary RCC with some clear cytoplasm. Again, out of context, could be clear cell RCC. Another differential might sound a little peculiar, like how could this be a differential? But in fact it is, and we wrote a paper on this. And that's clear cell renal cell cancer versus hemangioma of the kidney. And that's because clear cell renal cell cancer sometimes can be very paucicellular, where you have just relatively few tumor cells, very low grade, and basically when the tumors become kind of myxoid and paucicellular, what stands out is the vascularity and can be confused with hemangioma. But what you have to pick up is that all these very small dark cells that look kind of like lymphocytes aren't lymphocytes. They have this clear cytoplasm around them and they're clustered. And when you see that, you have to think, could this be a subtle clear cell renal cell cancer? Stain it with a pancytokeratin or a PAX8 or an EMA, any one of those will highlight the tumor cells. But here again is a subtle case of a clear cell renal cell cancer. When you look at this, you may not overtly recognize that some of these cells are cancer cells, until you do the stains. Here's EMA highlighting just some of these individual cells surrounded by EMA, which is diagnostic of a clear cell RCC. So in the kidney, when you get something that's kind of very cleared and myxoid, and you see these scattered cells present within those myxoid that aren't overtly lymphocytes, you have to have a low threshold to doing an epithelial stain to try to, or a PAX8, to try to say, could this be one of these low-grade clear cell RCCs? In contrast, this is a hemangioma of the kidney. They do exist. Most common hemangioma of the kidney is an anastomosing hemangioma, which is different. But you can also get capillary hemangiomas of the kidney, which is this example shown here. This is an example of an anastomosing hemangioma of the kidney. It's anastomosing hemangiomas are distinct hemangiomas seen typically in the kidney and the genitally and in both male and female genital organs. It's termed anastomosing because architecturally it looks like an angiosarc in that it has, instead of the nice rounded capillaries, if we go back to what we see in a capillary hemangioma, if you just look at the silhouette of the vessels, they're still rounded, discrete vessels. With an anastomosing hemangioma, the vessels are, they basically form these interanastomosing canals, like an angiosarc, but there's no cytologic atypia. Sometimes you see also extramedullary hematopoiesis in these lesions. Anastomosing hemangiomas of the kidney are also unusual in that sometimes they can form within the renal vein, not being in the kidney. They can just be this hemangioma rising in the renal vein. But again, architecturally, they have this very distinctive anastomosing pattern that looks like angiosarc, except the lack of cytologic atypia. Now going to switch to MIT family of translocation-associated RCCs. They're also just called translocation-associated renal cell cancers. These are in the differential of clear cell renal cell cancers. And there's two basic types. There's TFE3 rearranged, called mainly XP11 translocation RCC, and less commonly TFEB rearranged renal cell cancers, mainly 6 and 11. I'll show you the classic morphology of the TFE3 and the TFEB. Having said that, there's overlap between the two, and sometimes you'll look at a case and you might think, oh, this is going to be a classic TFE3 rearranged, and when you get back to molecular, it ends up being TFEB rearranged and vice versa. So there's, again, general kind of morphological correlates, but there's a lot of overlap. So TFE3 rearranged renal cell cancers have a wide age range. So we typically think of them as pediatric or occurring in younger children, and they do comprise the majority of pediatric renal cell cancers. So if you look at tumors in patients, for example, under 18 years of age, about 50% of them are going to be translocation-associated renal cell cancers. However, they're about 1% to 2% of adult renal cell cancers. And because adult renal cell cancers are so much more common than pediatric cancers, actually the sheer number of translocation cancers, they're more common in adults than in kids. And most of the ones that you see in your practice, unless you're practicing in a pediatric hospital, are going to be adults with translocation-associated renal cell cancers. And you can see wide age range, up to very elderly. Some of them are associated with prior chemotherapy, but most of them are just de novo, unclear why they occur. Prognosis is determined by stage and also age. Younger children tend to do better. So I'll show you some morphologies which can suggest translocation-associated renal cell cancer, where you would then do the special stains. We also have a low threshold at our institution where we see a lot of consults of doing some special stains, kind of screening stains to look for translocation-associated renal cell cancer for tumors that just don't fit anything else, even if their morphology isn't suggestive of a translocation renal cell cancer. So the stains that we do, if we're looking at something and I'm saying, is this a clear cell renal cell cancer or a translocation renal cell cancer? That's a common differential. If it's not classic clear cell RCC, the stains we would do are CA9, which is, again, I would recommend getting, cathepsin K, and right now there's actually a newer marker which virtually no one else has except for us, because we've done research on it in our institution. It's commercially available. It is now our go-to marker. It's become better than cathepsin K in terms of as a screening device for translocation renal cell cancer. It turns out this marker, GPNMB, translocation renal cell cancers are always diffusely positive, whereas clear cell RCC is never diffusely positive. It's also positive in some of the newer tumors that I'll talk about that have mutations in mTOR and TSC, and we'll talk about some of those. So we have found this new marker, GPNMB, to be very helpful because, again, if it's not diffusely positive, we know it's not a translocation renal cell cancer. Now, the way that CA9 is helpful, as I mentioned earlier, clear cell renal cell cancers are diffuse CA9 positive. Translocation renal cell cancers are never diffuse CA9 positive. So it's a good, simple screening test. If you have a case, is it a clear cell renal cell or not? If it's diffuse CA9, that's it. You don't need molecular, you don't need FISH. That's it. It's not a translocation renal cell. If it's not diffuse positive, then you have to consider what's the next step. There's also immunohistochemistry for TFE3, but for the TFE3 protein, we don't usually do that. It has a lot of problems with sensitivity and specificity. If it's diffuse strong TFE3 staining, that might suggest a translocation renal cell cancer, but you still have to do the molecular. But anything short of that, it's not that useful. What we typically do is FISH to demonstrate the TFE3 rearrangement. So what is the morphology of some of classic patterns of translocation-associated RCC? So one is a pattern that looks kind of like an alveolus soft part sarcoma, kind of nested clear cells, often has these dense calcifications as shown here. That's one of the patterns that you should be thinking of. Could this be a translocation RCC? Here's, again, another one of that kind of alveolus soft part pattern. Big nest. Typically, it's going to be grade 3 type cytology, big prominent nucleoli. Translocation RCCs, you don't have grade 1. You don't have the very bland cytology. So another thing that argues against a translocation-associated RCC is if some of the tumor looks very low grade and some looks high grade. That's not what you see in translocation. Translocation, it's pretty much uniformly high grade. Whereas that's common in a clear cell RCC to have a low grade area, grade 1 looking area, in, for example, a grade 3 area. But here we see these large nested areas with these calcifications. That's suggestive of translocation-associated RCC. The other pattern suggestive of a translocation-associated RCC is a mixture of a clear cell and papillary component with voluminous cytoplasm, grade 3 nuclei, intimate admixture of this clear cell and papillary component, and kind of throughout the tumor. So as I mentioned, you can have a clear cell RCC with focal papillary areas or papillary RCC with focal clear cell areas. With a translocation-associated RCC, those clear cell and papillary areas will be diffused throughout the tumor. So now let me shift to differential diagnosis of renal cell cancer with kind of denser eosinophilic or oncocytic cytoplasm. So amongst those is the TFE-B-associated rearranged RCCs. They can have very dense, even oncocytic-looking cytoplasm. Again, wide age range. Again, some of these can metastasize. A helpful immunohistochemistry for TFE-B-associated RCC is they often express HMB45 or melanin A. So that's, again, a good clue. And often these are often cytokeratin negative. Again, translocation-associated RCCs can look like anything, but the ones that are potentially distinctive on the H&E amongst the TFE-B translocation RCCs are tumors that have this dimorphic population. So what you see with that are areas that look like grade 3 nuclei with clear cytoplasm, and in the center, these very small nuclei that look kind of grade 1, high NC ratio, kind of little clonal proliferation of these smaller nuclei. That bimodal clonal population, when you see that, you should be thinking TFEB associated, translocation associated RCC. Now, another common differential, very common, is oncocytoma versus chromophobe renal cell cancer. So oncocytoma is entirely benign. So basically, when you have an oncocytoma, all you say is what's the size of the tumor, not from any prognostic standpoint, just we report size typically. Clinicians like to know, just correlate with imaging. We report the margins. We don't grade oncocytomas. They're entirely benign. And we don't mention if it's organ confined or not because oncocytomas, as I'll talk about, can go out of the kidney and have no prognostic significance. Chromophobe renal cell cancer, with exception of high-grade tumors, which are uncommon, well, I'll show you one in the slide seminar, chromophobes typically have like an over 90% cure rate. They have an excellent prognosis. They can metastasize. We do not grade chromophobe renal cell cancer. So one of the issues with grading renal cell cancer, the grading system for renal cell cancer is pretty much derived for clear cell RCC. Almost all the data for grading and all the studies that were done on grading were done with tumors which 90% were clear cells. So we grade papillary RCCs, but even then the grading system isn't as good a prognostic. It's not as tightly correlated with morphology as it is with clear cell. For many of the other tumors that I'll be talking about today, we don't give them a grade because they don't correlate with prognosis. And chromophobe is one of those. If we were to grade chromophobes, we would often call them grade 3, even grade 4, because a lot of them look kind of bizarre in the cytology. But as I mentioned, they have like a 95% cure rate. So first, let's talk about oncocytoma. So one of the most important diagnostic criteria for oncocytoma is low power. At low power, oncocytomas typically have a nested appearance in a fibromyxoid background. So by fibromyxoid, it's this light pink kind of not really collagen, kind of a myxoid matrix with these nests in it. 95% of the time when you see this at low power, it's an oncocytoma. Occasionally you go down to higher power, and as I'll talk about, there's cytology that rules out oncocytoma. But most of the time, it'll be an oncocytoma. And the cytology you're looking for is what you see in the inset, round nuclei. Now, oncocytomas can have prominent nuclei, even huge nuclei, as long as the nuclei are round. Some of the pitfalls with oncocytoma that can confuse you is one is the presence of oncoblasts. Oncoblasts are basically oncocytes with scanter cytoplasm. So on the right-hand side of this image is a typical oncocytoma cells. We have abundant, dense pink cytoplasm, small round nuclei. On the left, we still have the round nuclei, just scanter cytoplasm, so it looks more kind of high NC ratio, but that's still acceptable for an oncocytoma. As I mentioned, prominent nuclei, totally okay with an oncocytoma, as long as the nuclei are round. Now, oncocytomas architecturally are never diffuse. So at low power, an oncocytoma will either be those nests in a fibromyxoid background, or they will be back-to-back nests. So for example, on this image, these are still nests. You can still appreciate these nests separated by fine vascular network. It's not a sheet of cells. That's still consistent with an oncocytoma. When we get into chromophobe, you'll see chromophobes are a sheet of tumor or sometimes a diffuse kind of almost cribriform architecture. Now, when we look at the cytology of an oncocytoma and we're trying to assess, are these nuclei round? Are they still consistent with an oncocytoma? A pitfall is that you have to ignore pycnotic nuclei. It's common in oncocytomas to see these shrunken, crenated nuclei with very dark chromatin that are pycnotic cells, and these pycnotic cells will look irregular and scalloped on the edges. We basically don't even look at those. You ignore those and only look and assess the nuclei that have nice, good chromatin to see are those nuclei round. So if, in this case, if you look at all the other background nuclei that has nice open speckled chromatin, they're round nuclei, again, you just ignore all these little dark cells. And this is still good for an oncocytoma. Another pitfall with oncocytoma is the presence of degenerative atypia. So it is not that uncommon in oncocytomas to see typically clonal, sometimes diffuse, degenerative atypia. When it's clonal, meaning clustered, it's, I think, a little easier to recognize, but it'll stand out at low power as these bizarre nuclei. But basically, when you look at these bizarre nuclei, they're smudgy chromatin, pseudonuclear inclusions, multinucleated, degenerative chromatin. Despite this atypia, you won't see mitotic figures, you won't see necrosis. If this were a renal cell cancer, that was not an oncocytoma, but that this atypia was indicative of a high-grade tumor. With this degree of atypia, you would see something else indicating aggressive tumor. Again, mitosis, necrosis, growing out of the kidney, etc. But these are all degenerative, and if you do a Ki-67, for example, on a slide like this, this area, the oncocytoma, will be very low Ki. This area would be just as low. All those big cells will be negative for Ki. They're just non-proliferative. Another potentially worrisome thing about oncocytoma, if you're not aware of it, is that oncocytomas can go into the fat, sometimes quite extensively. When they do so, there's no stromal reaction. They just kind of go into the fat like this. Has no, again, prognostic significance. I often will mention it in the pathology report just in case some other pathologist looks at the case and says, how come this pathologist didn't notice that? But I also add a note saying this, again, is totally benign and has no adverse prognostic significance. Less commonly, but we've done several studies on this, long-term studies, oncocytomas can have vascular invasion and still be totally benign. They can even involve the major renal vein, as shown in this slide, and be totally benign. Now, before you call an oncocytoma with vascular invasion or renal vein invasion, obviously, same thing with myself, I think twice about it, make sure it's picture-perfect oncocytoma. But if everything is classic oncocytoma, cytology, architecture, and it's involving the vein, I'll call it an oncocytoma with vascular invasion and say this does not affect the prognosis. Now, what are the features that rule out an oncocytoma? One is irregular nuclei, other than the degenerative atypia that I talked about, and I'll show some examples of that. You should never see necrosis in an oncocytoma. You should never see papillary formation in an oncocytoma. You shouldn't see clear cells in an oncocytoma. The one exception is in the central scar. Often in oncocytomas, you have a central scar. That central scar is kind of an ischemic area of the tumor. And in that ischemic area, the cells get clear cytoplasm, and that's the one exception. Again, some pathologists say you should not see a single mitotic figure. To me, if it's a classic oncocytoma and I find one rare mitotic figure, I'm not going to change my diagnosis based on that. But again, there are different rules. Different pathologists have different criteria in terms of oncocytoma. There's only one immunohistochemistry that's helpful in oncocytoma. So often in my consults, I'll get more immunostains than H&E stains. And basically, vast majority of the time, 90% of those immunostains are worthless. And I don't look at them. Most of the time, it's very targeted immunostains that are helpful in renal pathology. So if you have the differential of oncocytoma versus chromophobe, there's only one stain that's helpful, and that's CK7. Oncocytoma should never be diffuse CK7 positive. If you have a tumor that's diffuse CK7, again, rules out oncocytoma. Patchy CK7 or negative CK7, still okay for oncocytoma. The one area in an oncocytoma that you see fairly good CK7 staining is in that area with the central scar. Those central scar with a clear cytoplasm, that ischemic area, those cells stain diffusely with CK7. Otherwise, you don't see that. Now, there's another papillary tumor that is oncocytic. So you remember that I just said if we go back to say what we don't see in an oncocytoma, we don't see papillary formation. So there is a tumor that is oncocytic and papillary, and it's a new entity. It's called oncocytic papillary renal neoplasm, again called neoplasm because so far it's been non-metastatic, but it's relatively rare, so we can't definitively call it benign yet. And it has this unique feature with inverted nuclei. Again, to date, no metastases. Some other unique aspects to this tumor has frequent KRAS mutations And from a diagnostic standpoint, you can use GATA3 with the marker that we use for urothelial cancer. Typically, it's negative in renal cell cancer, but it labels this tumor. So what you get is a papillary renal tumor, again, rules out oncocytoma. It, however, has that dense pink oncocytic nuclei, cytoplasm, and it has the reverse polarity. It has the nuclei again on the top, on the outer part of the cell, with the cytoplasm below it. So this is a distinctive, again, relatively new entity. Here, a little higher power. Again, oncocytic, but not oncocytoma, given its papillary nature, reverse polarity, and again, would be diffuse GATA3 positive. So now let me switch to chromophore RCC amongst tumors with eosinophilic cytoplasm. So the classic chromophore RCC is pretty easy to recognize. Some of the features of it, the cytoplasm can vary from being it's not clear like a clear cell RCC. It has this very delicate, light, pink, dusky kind of cytoplasm. Some of them can be more densely eosinophilic. The nuclei tend to have halos around them or corlocytosis. The nuclei are often binucleate, and they have crinkly, irregular nuclei, and I'll show you some higher powers of that. So here at higher power, again, classic features of chromophobe, kind of very, again, not water clear cytoplasm or glycogen clear, but it has that fine, dusky pink cytoplasm. Often what's described as plant-like cell borders, very well-defined borders you don't typically see in an oncocytoma. And the nuclei are what's described as racinoid. So what happens in a chromophobe, not every nucleus will have these irregular nuclei. Many of the nuclei will look regular, indistinguishable from an oncocytoma, but some of the nuclei, as you kind of look throughout the tumor, will have these irregular nuclei that once you see them rules out an oncocytoma. Oncocytoma should never have nuclei that have good formed chromatin. These aren't degenerative looking nuclei. They're not pycnotic, but they're irregular. They have little notches to them, almost like little proboscis, a little nose. Sometimes you'll see little like grooved nuclei. Seeing these basically rules out oncocytoma. Again, classic chromophobe. Many of these are nice and round, but these nuclei, basically nuclei like this, rules out oncocytoma. This is an eosinophilic variant of chromophobe, more difficult to distinguish from oncocytoma, very dense pink cytoplasm. But when you look at higher power, again, the classic racinoid or kind of notched nuclei, even though it's, again, most of these nuclei are round, the finding of any of these nuclei rules out oncocytoma. Now, as I mentioned, most chromophobes are low grade, and we don't grade them. We don't give them a formal grade, and they do well. But there is an existence of a high-grade chromophobe, and that's all we call it is high-grade chromophobe. And what you see in that is basically areas, the only way you can make the diagnosis is to have a low-grade chromophobe, typical low-grade chromophobe component, and then a higher-grade component where it's more cellular, hyperchromatic. What you can also see is numerous mitotic figures, which you would never get in a usual chromophobe. Here we see a typical mitotic figures, high cellularity, necrosis. Again, all features you would never find in a usual chromophobe, along with tumor acting more aggressively in terms of its local infiltration. Again, to summarize immuno, CK7 is usually diffuse in chromophobe. That helps you versus oncocytoma. But sometimes chromophobes can have patchy CK7, so it's not 100%. And then c-KIT, the one thing that's helpful with c-KIT, CD117, is it's diffuse in chromophobe. It's both also diffuse in oncocytoma, so that doesn't help you. But when we start talking about some other differential diagnoses of chromophobe and oncocytoma versus other tumors, c-KIT will be helpful. In the literature, you'll also hear about Hales colloidal iron, which is like an Alcium blue stain. I've never used it. Almost all GU pathology experts, no one uses it. It's not really helpful and specific. So again, not something I would use. Now, sometimes you look at a case and you say it's not an oncocytoma. It's not classic. I find a few irregular nuclei. I can't call it an oncocytoma. Maybe it's more of a diffuse architectural pattern. But it's not a classic chromophobe either, and it just doesn't fit with any category. And this is actually not uncommon, unfortunately. And so what do you do in that situation? So what we do is we call it a low-grade oncocytic neoplasm, basically a descriptive terminology. And we add a note. We say, although these features in this case are not classic for oncocytoma, the neoplasm is low-grade, and it's not diagnostic of a carcinoma. And we favor it'll have a benign clinical course, but we're not sure. Follow-up is warranted. In the past, we would have called these probably low-grade oncocytic renal cell carcinoma, but now we recognize there's a lot of these kidney tumors that have not been reported to metastasize. We're calling them, tumors and not carcinomas. So in a similar vein, when we see these low-grade oncocytic lesions that just don't quite fit, I don't want to label that patient as having a carcinoma. So this is an example that, you look at this tumor. It's not a classic chromophobe. It doesn't have the coilocytosis, doesn't have that delicate cytoplasm, but it's not an oncocytoma. Where the arrows are pointing, there are definitely some notched irregular nuclei that I would not want to say this is 100% benign classic oncocytoma. And so if you do everything else and you work it up with stains, et cetera, and this doesn't fit with anything else, I would call this low-grade oncocytic neoplasm, just like I said. Now, another issue that comes up with oncocytic lesions is oncocytosis. Oncocytosis is numerous bilateral oncocytic nodules where some of them look like classic oncocytomas, some of them will look like classic chromophobes, and some of them are hybrids, meaning, half the tumor looks onco, half of them look chromo. The other thing that you see in oncocytosis is little oncocytic nodules scattered throughout the kidney, not even making a tumor nodule, almost like an incipient oncocytoma. When I talk to clinicians who have patients with oncocytosis, I tell them the most important thing is basically you can't resect all of them because in that case you're going to do bilateral nephrectomies, put the patient on dialysis, which has a lot of morbidity and mortality. So basically you take out the biggest lesions and you just recognize you're leaving lesions behind that studies have shown typically don't behave aggressively. So ideally, patients should have nephron-sparing surgery. Some of cases of oncocytosis are sporadic, but some are associated with the Birt-Hogg-Dubé syndrome. And Birt-Hogg-Dubé syndrome is autosomal dominant. The hallmark is a skin, little nodules in the face called fibrofolliculomas. These patients also have pneumothoraces and all types of renal cell cancers. So it's important to recognize, again, especially for the ones that are syndromic. The other issue comes up is, can you diagnose oncocytoma on needle biopsy, make a definitive diagnosis? Again, some differing opinions amongst geopathologists. From my standpoint, I do not diagnose it definitively, and that's because I think I've seen a lot of tumors which have areas that out of context look indistinguishable from oncocytoma. When I've seen the whole tumor, it's not been oncocytoma, it's been carcinoma or some of these other tumors. So I think especially now, even with all these newer oncocytic lesions that have been coming up, I think to diagnose it on a needle biopsy is just, likely you're going to make a mistake. So what do I do on a needle biopsy if it still looks good for an oncocytoma, if I'm not going to call it? So what I use is a descriptive term, oncocytic neoplasm. In the note, I said if this biopsy is representative of the entire lesion, it would be consistent with an oncocytoma. However, renal cell carcinoma may uncommonly show focal areas with oncocytic features. Now, I've never had a problem with clinicians in terms of their response to this note. Most of the time, it'll depend what it looks like. So on imaging, if it looks like a small lesion, often with a central scar, older patient, and they get this diagnosis on the needle, sometimes they'll just leave it alone. They also sometimes can do in vitro ablation, like with putting cryosurgery into the lesion, and just basically ablating it there without getting any more diagnosis other than the needle. And if they're worried about it based on the imaging, they may take it out. This would be an example of something that I would use that note on. On a needle biopsy, this looks totally consistent with an oncocytoma. They're nests, so it's not a diffuse architectural growth pattern. Somewhat of a mixoid background, very bland cytology. Here at higher power, again, uniform cytology, nests of cells. If the whole lesion looked like that, that's an oncocytoma. But again, on a needle, I somewhat hedge my diagnosis. This was another needle biopsy of a kidney. And on the left, again, it has a little more delicate, lighter cytoplasm. And then a higher power, these nuclei basically would rule out oncocytoma. So on this needle biopsy, I'd say it's a chromophobe. Now, another kind of pink tumor in the differential of an oncocytoma that's, again, relatively recent diagnosis is SDH deficient RCC. Most of the time, SDHB deficient RCCs. And these are patients, almost all of them have germline mutations. Very uncommonly, it can be a sporadic mutation, but almost always these are germline. And it's associated with the familial paraganglioma syndrome. And what basically patients have either PHEOs or extraadrenal, paragangliomas. Some of them have a type 2 GIST, kind of pediatric GIST, associated with the Carney syndrome. And then there's a 14% risk a lifetime for renal neoplasms. So SDH deficient RCCs are uncommon, less about 0.5% of renal cell cancers. Typically young adults, some are bilateral. Most of these are indolent, but some have metastasized. Some cases of SDH deficient RCCs, I'll show you the classic morphology of SDH deficient RCC. It's been shown that occasionally, rarely, you can have a tumor that actually doesn't particularly look like an SDH deficient RCC that loses SDH. That the only way you would ever detect it is if you stained like every tumor that doesn't quite fit with SDH, which we don't do. I'll tell you how we handle kind of tumors where we're not sure of in a minute. So again, rare cases can metastasize either that look like classic SDH deficient RCCs or ones that look more aggressive. And some of these can metastasize very late after resection. Again, almost always germline mutation. So in terms of when to start doing kind of a workup, major workup for renal cell cancers. So again, often for clear cell tumors, we'll do the kind of the GPNMB, cathepsin K, CA9 for kind of translocation versus clear cell. GPNMB also stains, as I mentioned, some of these other tumors that I'm going to be talking about, so it's kind of a general screening. In a young patient, and by young I would probably say 40 and below is my kind of criteria for young. If something doesn't quite fit, I will often do SDH, immuno, and FH. So we'll talk about fumarate hydratase. Tumors that don't quite fit over 40, I often won't do those. So this is the classic morphology of an SDH deficient RCC. It's low grade, tends to be more of a sheet-like growth, very delicate, light eosinophilic cytoplasm, perfectly round nuclei, and then the hallmark of the SDH deficient RCC are these little vacuoles. Some of them are clear, but some of them are more contain kind of this pale, watery, serous kind of fluid, and that's classic SDHB deficient RCC when you see this morphology. Here's another example where it's kind of the cells are falling apart, looking a little bit more tubular, but again, that perfectly round uniform nuclei and the vacuoles. This is a rare case of a high-grade SDHB deficient RCC, which, again, you wouldn't necessarily think of it. This was a younger patient, and that's when we did the workup that had lost SDH. And here's the immuno. Immuno is striking. It's all or none. So the SDH will stain background normal tissue like vessels, so you always have an internal control, and the tumor will be entirely lost in SDHB deficient RCC. We also use SDHB for paragangliomas outside the adrenal because it's a prognostic, the higher risk of having malignancy, and also potentially, again, if it's lost, being associated with a familial paraganglioma syndrome. Another relatively new entity in the kidney is eosinophilic solid and cystic RCC, ESC RCC. Again, I'll show that during the slide seminar, so I think with a lot of these newer tumors, it'll just help to be reinforced, just seeing them, and kind of on the slide seminar, when I kind of drive around, it also more approximates how you would approach it when you get it across your desk. Now, with ESC-RCC, the vast majority are sporadic, but rare tumors have been seen in patients with tuberous sclerosis. Again, most of these are indolent, but because some of them have had metastases, we call these carcinomas, not tumors. They typically have biallelic somatic TSC1 or 2 mutations. And some of the patients, it's important to recognize them because some of the ones who've had metastases have responded to mTOR inhibitors. And I mentioned again this GPNMB marker. GPNMB diffusely labels tumors with mTOR mutations and TSC mutations. So, for example, ESC-RCC labels diffusely with GPNMB. And it's a good almost screening device if you're considering it. Now, ESC-RCC is one of these tumors that I think you can diagnose on the H&E, along with the CK20, as we'll talk about. So you don't need molecular to diagnose this entity. It's, I think, distinctive enough morphologically. And so I guess the good and the bad with kidney tumors is they're all kind of descriptive names. The good about it is, again, sometimes like I'm sitting with, literally last week, I was going over unknowns with my fellows. And I'm saying, they're describing it. And I said, what do you think this tumor is? And we were going through kidney tumors. And they said, it's solid, and it's cystic, and it's eosinophilic. And they were still like clueless, like, what is this entity that they're looking at? I said, okay, you have something that's eosinophilic, solid, and cystic. Does anything sound like that, in terms of, eosinophilic, solid, and cystic renal cell cancer? So sometimes those names are helpful, but sometimes it sounds like they're all confusing. They all sound alike. So it's a mixed bag. But in this case, I think it's helpful. If you see a tumor that's pink, solid, and cystic, again, think ESC-RCC. So on the top, here's the solid area, and here's the cystic component. The cystic often has little hobnails poking in. Now, ESC-RCC can have a wide range. You can have a tumor that's pure solid or almost all cystic. So the ones on either end of the spectrum are a little harder to recognize than the ones that are more evenly solid and cystic. Here's one that's more cystic, but again, it's these pink cells lining the cystic tumor, kind of protruding into the lining a little bit with a little hobnail morphology. And then the other thing, once you look at low power and think, okay, this could be an ESC-RCC, the thing you want to look for, and it's present, I would say, pretty uniformly throughout the tumor, it's not like you have to hunt and hunt and hunt to find it, is with these clumped stippling, these amphiphilic stippling of the cytoplasm. So what you see is these purple, coarse, irregular, clumpy granules kind of in the cytoplasm. And it's present, again, diffusely enough and prominently enough that if you look for it, you'll find it in these ESC-RCCs. And then basically the one final thing that you need to do to maybe feel more comfortable to arrive at a definitive diagnosis is CK20. So the one thing about CK20 is, with the exception of some translocation-associated RCCs that can have some CK20 staining, virtually no other kidney tumor is CK20 positive. So in this particular case, CK20 is helpful in establishing the diagnosis of ESC-RCC. There are some cases of ESC-RCC in the literature that are CK20 negative. I would say, obviously, much harder to diagnose unless it's just classic morphology. Another case of an ESC-RCC, again, nice solid areas, cystic component, dense pink cytoplasm, higher power, that dense pink cytoplasm, and nuclei, again, are going to have some kind of grade 2 to 3 nuclear features. This is nice, showing kind of the hobnail pattern, these little rounded cells poking into the cystic spaces. Another feature of ESC-RCC, it's not uncommon to find little patches of inflammation, like little lymphocytic foci within the tumor, which is not that common in other renal cell cancers. And then, as I mentioned, the stippled amphiphilic little inclusions within the cytoplasm. And in this case, CK20 is a little bit more prominent. Another pink tumor is the eosinophilic and vacuolated tumor, EVT. So initially it was reported by another group as high-grade oncocytic tumor, or HOT. That term is not the preferred term. The high grade refers to cytology, as I'll show you. They have prominent nucleoli. It's a bad term because these basically so far have never metastasized. That's why we're calling them tumors, not carcinomas. And so high grade sounds like it should be a malignant lesion. So a better term is more this descriptive eosinophilic vacuolated tumor, EVT. These are CK20 negative, cathepsin positive, and again, they have somatic TSC mTOR mutations, so they're positive for GP and MB, which we have found to be helpful at our institution. This is, again, a tumor that I think you can diagnose based on morphology. It has distinct morphology. You don't need to do molecular diagnosis. I think there's a kind of misconception that renal cell carcinomas have become so complex, so many cases out there, we need molecular to diagnose them. You know, I can't diagnose them in my practice if I don't have molecular. And the answer, I think, is yes, there's a subset that may be the case like that, but I think many of these tumors you can diagnose just on the H&E with maybe very limited immuno and readily available immuno. So eosinophilic vacuolated tumor stands out. Number one, it's a pink tumor. But it's striking in that all the tumor cells have these vacuoles. And when you think of it, there's really no other kidney tumor that has this. So that's why I'm saying you can diagnose it on the H&E. When you go to a little higher power, again, a pink tumor, variably sized vacuoles. Some of them are kind of small, some are almost tubular, larger. But it's present throughout the tumor. It's not a focal finding. But cytologically, the nuclei are high grade. And that's why with kidney pathology, number one, grading obviously doesn't apply. This isn't even carcinoma. But if you were to grade this, you would be grading this as some high-grade lesion. But in fact, so far, none of them is metastasized. So you have to know what the entity is before you start assigning a grade or not assigning a grade. And many of these tumors that I'm talking about, we don't give it a grade because they're actually benign or the grade doesn't correlate with prognosis. Another kidney tumor that's been around a little bit longer is acquired cystic kidney disease-associated RCC or ACKD-RCC. It's unique in that it's only seen in end-stage renal disease. All the other tumors that I've talked about, some of them can occur in end-stage renal disease because end-stage renal disease, all types of renal cell cancers can occur, but this particular tumor can only be seen in end-stage renal disease. Some of them are multifocal, some can be bilateral. Typically, these tumors do pretty well, and they often can be somewhat cystic. And it, again, has classic morphology. Stains, no immuno needed, no molecular needed. Basically, there's three things that you have to make the diagnosis. It's eosinophilic, first of all, so it's in this pink, kind of general pink tumor cell family. It's described as being sieve-like. So the term sieve-like is a little confusing. So if you look up the definition of cribiform in a dictionary, so cribiform I think of as like Swiss cheese, sheet punched out holes. If you look up the definition of cribiform in the dictionary, it actually comes from the word sieve-like. Now, in renal pathology, we use the term sieve-like a little bit different than cribiform. We use sieve-like for a cribiform process, so it's still a sheet with punched out holes. But what we refer to when we talk about sieve-like is that it's basically flattened cribiform structures. It's not like a nice Roman thick bridge, like when you think of intraductal cancer of the breast or intraductal cancer of the prostate. It's these thin, flattened spaces, basically, kind of attenuated cribiform processes. So you basically have very big open lumina with just very fine fenestrations. That's classic of ACKD-RCC. And then the third component, after the eosinophilic cells, the sieve-like formation, is the oxalate crystals, which you typically will find in these entities. Now, you don't need the oxalate crystals to make the diagnosis of ACKD-RCC. They're often present, but again, they're not essential. You can also have, and we described, precursor lesions to ACKD-associated RCCs, which are cysts, which have the same lining of ACKD-RCC, but they're purely cystic without solid foci. So here again, we see these big cysts in an end-stage renal disease. And when we look at these cysts, they're lined by these pink cells with these little vacuoles, and we even have the oxalate crystals. So it's basically the same cells as ACKD-RCC, but not solid. So these are precursor cysts, and without solid component, you don't want to label that patient as having a cancer. Now, in the differential of oncocytoma is another kidney tumor that's relatively uncommon, not rare, but uncommon, and that's tubulocystic renal cell carcinoma. Again, I'll show an example of this during the slide seminar as well, which will also just reinforce it. So tubulocystic RCC is male predominant. They're indolent tumors, but still can metastasize, so we call them carcinomas, not tumors. And at low power, the way I tend to think of them also use the analogy of Swiss cheese. So it's a well-circumscribed tumor, non-infiltrative, but big cystic spaces, but variably sized, but typically not small tumors. Not everything's somewhat cystic, just variably sized cystic. So when you see that, you should be thinking tubulocystic. Also in the differential might be cystic nephroma, but as you'll see, you have no ovarian-type stroma, which you get with cystic nephroma. And then the key thing versus oncocytoma is tubulocystic carcinoma has grade 3 nuclei, but they're irregular. They're not the perfectly round nuclei that we see with an oncocytoma that we just showed you before. Here's another tubulocystic carcinoma with very oncocytic-looking cells, but these nuclei are more irregular. If you look at these nuclei, these are not the nice round nuclei of an oncocytoma. Oncocytoma, people aren't as familiar with. Typically, we think of them as a nested tumor, like I showed you, but oncocytomas can also have a tubular component, which again can be confused with tubulocystic RCC. The difference is oncocytoma will typically have some areas that are going to have more solid nests. Classic oncocytoma, which you would never get with the tubulocystic. Tubulocystic never has these small little nests. And then, oncocytoma with tubules sometimes will have some degenerative atypia. But the nuclei will be totally round, like all other oncocytomas, in contrast to tubulocystic carcinoma. Here's an oncocytoma with a cystic component. In contrast to tubulocystic cancer, we have the small solid nests, as shown here, which you would not see with the tubulocystic. Now, tubulocystic carcinoma can uncommonly have poorly differentiated foci. So basically, that's when you have a more aggressive component in the tubulocystic cancer. It's important to recognize them because whereas tubulocystic cancers are only rarely metastasized, once you have poorly differentiated foci, high risk of metastatic disease. Also, interestingly, a high percentage of these lose fumarate hydratase. But most of these are still sporadic, not associated with hereditary leiomyomatosis renal cell carcinoma syndrome, which I'll talk about shortly. So this was a case of a tubulocystic cancer with a papillary component. This is inconsistent with tubulocystic carcinoma. So this would be tubulocystic cancer with poorly differentiated foci. Here is tubulocystic carcinoma in the upper left. Here's this solid high-grade component here, which at higher power is composed of tubules and individual cells, with almost like looks like a collecting duct carcinoma with a desmoplastic stroma. This is tubulocystic carcinoma with poorly differentiated foci. Another pink cell tumor that's a new entity, and this is one is more controversial. So some people think it as, quote, provisional, meaning is this really a distinct entity or not? In my opinion, this is a distinct entity. I've now seen enough of these that are just all the same, picture perfect, stain the same, look the same, that I'm comfortable that this is a real lesion. And it's called low-grade oncocytic tumor. Kind of, in my opinion, it's kind of a bad name because I've experienced this with clinicians, that if you sign this out as low-grade oncocytic tumor, the clinician thinks you're describing some kind of general thing, not like a specific entity. It's almost like, before I talked about when I'm not sure what it is, I use the term low-grade oncocytic neoplasm with a note. Some clinicians, if they get back this entity, low-grade oncocytic tumor, they think, okay, but so you don't know what this really is? And the answer is no, it's this low-grade oncocytic tumor. It is a specific entity. So when I sign these lesions out now, I will actually say this is a specific entity, and I give the reference to make sure that the clinicians know that this is indeed an entity, not just a generic description of something low-grade non-acidic. So, and the kind of abbreviation is LOT. So it looks basically at low power like a eosinophilic chromophobe RCC. But the difference is the nuclei are perfectly round. So even though there are halos, coriocytosis like a chromophobe, in contrast to the crinkly nuclei of a chromophobe, all the nuclei of these look like an oncocytoma, but they have halos around them. Also, if you remember, chromophobes are always diffuse c-KIT positive, CD117 positive. That's the one stain you want to think about with chromophobes. This tumor, c-KIT is negative. CK7 is typically diffuse positive, c-KIT negative. So that's a classic immunohistochemical profile that's specific for low-grade oncocytic tumor, LOT. The other morphology that's classic for this is basically, as I'll show you, what's described as archipelago-like morphology, where you get these little tiny little nests in a myxoid background, kind of resembling, the islands in an archipelago. And these tumors are also associated with TSC mutations, so again, a GPNMB positive, but none of these tumors have metastasized to date. So here's a LOT. So a LOT, basically pink tumor, somewhat diffuse architecture. You might think of an SDHB deficient RCC in the differential because it's bland and pink. But the difference is that basically the nuclei have halos around them, but are not crinkly nuclei. Here is kind of this myxoid matrix with these nuclei that are round but striking halos. And this is the classic archipelago pattern in a LOT, where you get these thin, kind of teased out little nests of cells, almost been described as almost like fibroblastic-like, tissue culture-like, almost stretched out cells in this myxoid matrix. Turning to another entity, and I know these, again, are a lot of entities, but we're going to go through them again in the slides and talk about them again, so you'll get hit with it again. So another entity is hereditary leiomyomatosis-associated RCC, or HLRCC. So HLRCCs, the syndrome is a germline mutation with the FH gene, the fumarate hydratase gene. And clinically, these patients present with multiple cutaneous and uterine leiomyomas, and the uterine leiomyomas tend to present at early age in women. 1/3 of these patients have renal cell cancers, and the key thing is that these are aggressive cancers, typically often present with metastatic disease or shortly thereafter have metastatic disease, and lose the fumarate hydratase by immunohistochemistry, and overexpress, so it's all in the Krebs cycle. So the precursor to FH in the Krebs cycle is 2-succinylcysteine, 2SC. And so basically, if you lose FH, you have basically a buildup of 2SC. So you can both demonstrate these tumors immunohistochemistry, showing a loss of FH, or diffuse 2SC. Either one works. We have both antibodies in our laboratory. Most people would have FH, and most of the time that suffices. There are rare cases where the fumarate hydratase protein is basically dysfunctional, and so it's FH positive, but it's not functional, associated with the mutation in the FH gene. And in those cases, the 2SC will be positive and can help in the diagnosis. But most of the time, FH is good by itself. So the story with FH in deficient RCCs is there's a classic morphology that I'm going to show you, and I'll show you on the slide seminar as well. So when you see this morphology, that's when you think, oh, let's work it up for FH, deficient RCC. Unfortunately, there's also a fair number of RCCs that don't look classic that also lose fumarate hydratase. So again, how do you find them? And so from our standpoint, on my standpoint, I will only start screening with FH for an unusual renal cancer that doesn't fit in somebody 40 and under. Or if they have stigmata suggested by the clinician of HLRCC. But otherwise, you would do it on every tumor, and law of diminishing returns. What is the classic morphology for an FH deficient RCCs? Typically, it's papillary RCC, And the other hallmark is what's described as kind of CMV-like nucleoli. Huge cherry red nucleoli with the clearing around it that, again, looks like, like an owl eye or a CMV-like nucleus. When you have FH deficient RCCs, this cytology is typically diffuse throughout the lesion. So a lot of times in renal cell cancers, you can see this focally, non-specifically. But again, in FH deficient RCC, it's going to be diffuse. And just like the SDH stain, it's striking because the vessels will be positive, everything else dead, entirely negative. Another example of an FH deficient RCC, this one's not as papillary, but again, we have those nice big cherry red nucleoli, loss of FH. So most of the time, when I sign out a tumor that's I've shown to lose fumarate hydratase, I don't know if the patient has a syndrome or it's sporadic. 80% of them end up being hereditary, 20% are sporadic. But again, from a pathology standpoint, I can't make that distinction. So the way we sign these lesions out is just fumarate hydratase deficient renal cell carcinoma. And in a note, we say, this may be associated with HLRCC, maybe sporadic, clinical correlation is necessary. I'm going to end with a differential diagnosis of some spindle cell lesions in the kidney, briefly. So first is angiomyolipoma versus normal fat. And you think, how could that be a differential? So this is your classic angiomyolipoma. Classic AML has three components. The angio component is not just vessels. Every tumor has vessels, but it's distinctive vessels. And what makes them distinctive is that the vessels, a normal vessel would have a very well-defined outer adventitial edge, a border where the vessel stops. If you look at a vessel in angiomyolipoma, the smooth muscle of that vessel just keeps on going and going, merges with the surrounding tumor. It never has an outer border to it. That's the unique angio component. And then we have the myo component, which is the pecoma cell, perivascular epithelioid cell component, modified smooth muscle cells, and the fat. So this is a classic AML. Here, a little bit higher power. Now, what makes also it's critical to recognize is that the muscle component looks different than, for example, a leiomyoma. What's unique of the smooth muscle in a angiomyolipoma is that it's a very delicate, light pink cytoplasm, very filamentous. I call them spider cells, spiderweb cells, as we'll see shortly. Now, angiomyolipomas can arise in the kidney, can rise in the outer cortex of the kidney, can rise in the retroperitoneal fat, they can rise in the spleen, rise in the liver, GYN tract, all over. But in the kidney, they can arise outside the kidney, which can be a problem, or arising from the outer surface of the kidney, because the biggest risk with angiomyolipoma clinically is these vessels with this abnormal kind of wall around it are prone to rupture. And when it ruptures and the angiomyolipoma is out of the kidney, it can rupture into the retroperitoneum and result in fatal hemorrhage. So if it was in the kidney, the capsule of the kidney would contain the hemorrhage, and patients aren't going to die. But with angiomyolipomas, there's this risk of fatal death or fatal hemorrhage. So what can sometimes happen, which can be tricky to recognize versus just normal fat in angiomyolipomas, is you can have a very fatty predominant AML in the retroperitoneum or rising outside the kidney that if you don't know what you're looking for, you might just think looks like fat. But the key thing is, even at low power, noticing there's, this is normal looking fat kind of here, but there's more kind of pink here than there should be in fat. And when you go to higher power, what you see are the delicate pink filamentous cytoplasm that's classic for angiomyolipoma cell or pecoma cell, and that's what you have to recognize is a fatty AML. Just that the interstitium in between the fat is expanded by this delicate little pink cells with this filamentous cytoplasm. Angiomyolipoma can also involve lymph nodes. They're not malignant, it's multifocal. Immunohistochemistry, they're positive for HMB45 melanA. However, it can be extremely focally positive. So that's another pitfall. Is I've seen many cases where people thought it was an AML, but the stains were not that striking, and that made them confused. Another good marker for angiomyolipoma is cathepsin K. They're diffusely positive. Also GPNB, diffusely positive in angiomyolipomas. Desmin is also positive in these lesions, as can S100, so just to be aware of that as well. But these are benign. As I mentioned, they can involve the lymph nodes, but the mortality is due to the hemorrhage. I'll show you an example of epithelioid AML with atypia in the study set, but I'll just briefly go over one here. So you can get leiomyosarcomas in the kidney. Leiomyosarcomas that never arise, actually, it's kind of a misnomer. Leiomyosarcomas never arise in the kidney. You don't get smooth muscle tumors in the kidney. There is no smooth muscle really in the kidney. Any smooth muscle tumor that's arising kind of from the kidney in general is arising from the hilar vessels of the kidney. So when you get a leiomyosarcoma, it's arising from the renal veins. It's actually going to be in the hilum of the kidney, not in the kidney. If you see something that you think is a smooth muscle tumor in the kidney, it's an angiomyolipoma. Now, I've shown you classic angiomyolipomas. There is an entity called epithelioid AML that can have atypia that can, if you're not sure what it looks like, doesn't bear much resemblance to an angiomyolipoma. It has, number one, looks overtly malignant. It has what we call amoeboid cells, these giant malignant-looking cells with abundant pink cytoplasm, very epithelioid. Looks like a high-grade renal cell cancer. Here again are these giant, huge, almost amoeboid cells. Again, they're going to be staining just like angiomyolipomas. They're going to be negative for keratins, negative for PAX8, which helps to differentiate them from renal cell cancer. We came up with criteria for malignancy in these angiomyolipomas, and you basically need 3 out of the 4 features. Either over 70% has these atypical epithelioid features, finding basically just a few mites per 10 high-power field, any atypical mitotic figure, and necrosis. Here's a malignant angiomyolipoma, with atypical mitotic figures, necrosis, these big amoeboid cells, positive for HMB45. And the last entity we'll talk about is sarcomatoid renal cell cancer, which is not that uncommon, versus leiomyosarc. Again, as I mentioned, one of the key things is where is it arising from? If it's in the kidney, it's not going to be a leiomyosarc. So sarcomatoid renal cell cancer is not really a specific type of renal cell cancer. It's basically a pattern of sarcomatous dedifferentiation or sarcomatous differentiation that can arise in any type of renal cell cancer. So you can have sarcomatoid chromophobe renal cell cancer, which I'm showing here, sarcomatoid clear cell, sarcomatoid collecting duct, sarcomatoid papillary. But once you have that sarcomatoid component, it's by definition grade 4 and associated with a very poor outcome. But sometimes we see a spindle cell tumor, malignant spindle cell tumor in the kidney that doesn't have a recognizable epithelial component. We can't find clear cell RCC, papillary, or chromophobe. We just get something that looks like this. So when you get something like this in a nephrectomy, for example, 95% of the time it's a sarcomatoid RCC because it doesn't conform to any classic sarcoma morphology. It doesn't have the nice fascicles of a leiomyosarcoma, or doesn't look like any other type of sarcoma. It's like just haphazard malignant spindle cells. How do you establish a definitive diagnosis of a sarcomatoid RCC in that case? As I'll talk about, you have to show it with epithelial markers. But here's a leiomyosarcoma in contrast, and you can see it nicely arising from the renal vein. And in contrast, leiomyosarcoma is going to have nice fascicular architecture, cut and cross-section, and coming kind of out of the plane of section. Even in pleomorphic leiomyosarcomas like this, areas of the tumor will still retain their fascicular growth pattern. So to diagnose a sarcomatoid RCC in the absence of well-recognizable carcinoma component, you basically have to do a high molecular weight keratin or pancytokeratin to demonstrate that. So to summarize, and this will be the ending, most renal tumors I think you can diagnose on H&E with a limited immuno. Clear cell RCC, you can do it on morphology, diffuse CA9. Again, recognize CK7 may be positive in some of the low-grade clear cell RCCs. Clear cell papillary renal tumor, again, I think morphology, you can do it. If you're not sure, do the CK7 diffuse, CA9 diffuse. Chromophobe morphology, diffuse CD117. Oncomorphology and not diffuse CK7. Tubular RCC, purely morphology. acquired cystic kidney disease, RCC, purely morphology. ESC, RCC, morphology plus CK20. SDHB, most of the time morphology plus the immuno for SDHB. Eosinophilic vacuolated tumor, most of morphology, plus or minus cathepsin. And then low-grade oncocytic tumor, morphology, and then the c-KIT being negative with the CK7. So there are also some renal tumors, I think, that you can suggest a diagnosis on the morphology, but you do need immuno or molecular to be definitive, such as the FH deficient RCC, translocation RCC. But then I think it's also important to recognize, and not to feel bad about it, is that still after doing everything, it's not that uncommon in kidney tumors that you sometimes end up with an unclassified RCC. I think it's important when you diagnose something as unclassified RCC, still say low-grade or high-grade. Because if you just call it unclassified, clinicians think it's unclassified because it's some horrible tumor. And many of these unclassified tumors are low-grade and still probably do quite well. And with that, I'll stop. Thanks very much.